All right, so this is the final PowerPoint of the three sections for the hematologic issues. We're going to start out with going a little bit over some cancer-related topics, and then we will finish off with some hyperbilirubinemia. All right, so pediatric cancers versus adult cancers. So childhood cancer usually affects the tissues. They arrive from the embryonic cells or are leukemias or lymphomas. They're most commonly found in blood, lymph nodes, brain, bone, kidneys, and muscles. When it related to the environment and lifestyle, only a very small amount of environmental influence is proven with childhood cancers. In fact, with that being said, there is little known about the prevention of cancer in children. Detection of childhood cancer is usually incidental or accidental. The metastasis is often present at diagnosis with childhood cancers, and childhood cancers tend to be more responsive to treatment. When we look at adult cancers usually affect your organs or your epithelial cells. Most common sites for adult cancers would be breast, lung, prostate, bowel, and bladder. We know the environment and lifestyle factors has a strong influence on cancer development in adults. 80% of adult cancers are preventable. We know that with early detection and screening recommendations that we can find adult cancers easily. Metastasis is less often with adult cancers at diagnosis. So with adult cancers, the metastasis usually occurs after treatment, or if treatment is not being chosen as a response to the cancer. And adult cancers tend to be less responsive to treatment. We also know that there's an 80% survival rate for children with cancer, so that is a positive thing as well. So warning signs of cancer. So some things we might see in that child that could give us an indicator that they could have a form of cancer. Fatigue, pallor, frequent infections, easily bruising, that abdominal or bone swelling, pain in their body, discharge. To diagnose cancers, we're going to look at CBCs, liver function test, BMPs, blood urea nitrogen. They're going to do PET scans, lumbar punctures, bone marrow aspirates, MRIs, CT scans, and biopsies. Some different treatments, and we will look at a few of these later on. Surgery, chemo, radiation, and bone marrow transplant. Some side effects of therapy would be infection, hemorrhage, anemia, nausea, vomiting, altered nutrition, mucosal ulceration. And remember, with those mucosal ulcerations, that also could cause bleeding of the gums and irritation there. It can affect their nutrition, put them at high risk for blood loss. They can have neurologic problems, and then hemorrhagic cystitis. All right, guidelines for the preparation of chemotherapy. We talked about this with osteosarcoma and Ewing sarcoma, so I'm not going to go through it again, but just keep this under mind when we're looking at these kids with cancer. Also something very important to think about. Once again, the adverse effects of chemotherapy, we are going to go through, we went through with osteosarcoma and Ewing sarcoma, so I'm not going to cover them again and read through these slides through. But remembering that some of the side effects of chemotherapy and radiation therapy, we are going to see some of these things before diagnosis, but certain ones will only be seen with the treatment, such as alopecia. Hair loss does not occur until they've already started treatment. All right, radiation therapy. Once again, we've discussed this, so I'm not going to go in depth on it. All right, bone marrow transplant. These kids with cancer are sometimes able to get bone marrow transplants, remembering with transplants that we need to make sure that the donors are very compatible. So lots of screening is done to to find out if we have a donor that could donate to our patient that needs it. It's very hard to sometimes find that perfect donor. We can do umbilical cord blood stem cell transplants. So when moms and dads are having their first child and frequent children after that, they can actually save that umbilical cord and put it in for cryogenics to save it. And I believe it can be saved for multitudes of years. Double digits, and especially if they know there's like a family history. Now there's a cost to it as well, but they can save their own child's umbilical cord, and then they can maybe use the child's stem cells to treat their cancer. Autologous bone marrow transplant. This is when the own patient donates his or her own bone marrow from disease-free tissue, and then it can be used to hopefully treat their form of cancer. Kind of cool to think about that. So neuroblastomas, Hodgkin's lymphomas, Wilms tumor. Ewing sarcoma is another one. So they could take the bone marrow from another bone and maybe use it to help the child. And of course, when it's their own bone marrow, there's less likelihood for transplant rejection. Okay, so we have peripheral stem cell transplants. This is once again another form of autologous transplants. It's also collected from the patient, and then this also has less effects on that child for rejection. Since we're talking about some transplant things, just remember there's long-term side effects when we have transplants. And each child is going to respond to transplants differently, but rejection is a huge thing. So you need to think about these kids are going to be on anti-rejection meds long-term. They're going to have to watch what they're eating and drinking. They are at high risk for all sorts of things. Some kids end up with GI issues with rejection, some don't. So it's just unique symptoms, fevers. But it could also be pain at a site. It could be different things like that. All right. So leukemia, which is the most common form of childhood cancer, 3 to 4 cases per 100,000 children younger than 15 years old. It is more frequent in males over the age of 1, but it typically is, the onset is between the ages of 2 and 6, so those toddlers and preschool age kids. My husband is a pediatric leukemia survivor. He was diagnosed at 4.5, I believe. So things to think about. Huge survival rate for these kids. However, when you think about it with survival rate with leukemia, Kids that have leukemia as a child are at higher risk for other forms of leukemia as an adult, especially if they participate in things that could increase anybody's likelihood of developing cancer. All right, so classifications of leukemia. We have ALL, which is acute lymphoblastic leukemia, which is the most common form, and then acute non-lymphoid myelogenous leukemia, or AML. ALL is more common in young children and actually has a higher survival rate. AML is less likely in children, but it does occur, and its survival rate is lower. ALL is highly responsive to treatment. AML tends to be less responsive to treatment. In fact, with AML, they are more likely to go to bone marrow transplants and things like that quicker than with ALL. With ALL, they'll try to just do the chemotherapy and radiation a couple times if there's relapsing. When I was talking about later in life for pediatric patients with cancer, those kids that have ALL as a child are at higher likelihood of developing AML as an adult, especially if they are smokers, if they are exposed to carcinogens in their jobs and things like that. Those things then once again increase their likelihood. All right, some pathophys of leukemia. Hopefully for you guys that this is common sense. This is where I think there's some disclaimer or a misunderstanding in lay people or the normal population. We have these leukemic cells that proliferate into the blood and body. These leukemic cells are then fighting for the same nutrients and everything that the healthy cells, white blood cells in the patient's body is all vying for. So what ends up happening is these leukemia cells, these immature white blood cells, then overtake and not overtake, but they are then stealing away what the healthy white blood cells need, and therefore the healthy white cells don't get the nutrition and everything they need to live, and they die off, and that allows the leukemic cells to live. When I've heard lay people talk about it, my mother-in-law is one of them, a lot of people say my child has leukemia, and the leukemia is attacking the child's body and attacking the healthy cells. And really that's not what's going on. They're just fighting for the same things, and the leukemic cells win. So some things to think about with leukemia. This leads to weakened bones, so they can have severe bone pain. The leukemic cells will then get into the periosteum, and that's what causes it to be weakened. They can become severely anemic. Infections due to neutropenia. They are at high risk for bleeding tendencies. So hemorrhages, things like that. So when they have those sores in their mouth that are getting irritated, easy for them to bleed and their gums to bleed and have hemorrhage. Bloody noses could be an issue with these kids, and those could become hemorrhages. Some things to think about there. But also their spleen, their liver, their lymph glands can all become infiltrated, enlarged, and fibrotic. So that can cause problems. We want to make sure that we are keeping a close eye with these kids when it comes to things like chickenpox. These kids may not be able to get the chickenpox vaccine because it's a live vaccine. So if they end up getting leukemia during that part of the schedule, they can't get it. So that puts them at higher risk for exposure to chickenpox. Or maybe they're too young to get the vaccination yet, and so if they get exposed to leukemia, it could actually kill them. Or if they're exposed to chickenpox, it could kill them. Protozoas, fungals, pseudomonas, klebsiellas, staphylococci. These are all different modes of infection that could be deadly to these patients. So we need to be very careful with these patients when they're out and about because of the neutropenia. Okay, diagnostic evaluation. We talked about some of these things. So we're going to look at their whole history and physical manifestation. We're going to do blood smears. This is going to give us an idea of how much immature leukocytes are floating around in their system, and they tend to have lower blood counts. We're going to do a lumbar puncture. The lumbar puncture isn't going to tell us that they have leukemia. What it's doing is to see how the CNS system is involved and to see if there's any other infections and things going on. Bone marrow aspirations or bone marrow biopsies to once again see what is all involved and to see if the leukemia is now getting into other parts of the body. So therapeutic management, chemotherapy, most common form of treatment for leukemia. So they're going to get ports or PICC lines put in because chemotherapy agents are very corrosive to the body. And so this will protect them. It's not uncommon for them to also get cranial irradiation. So that irradiation, that's very centralized. Something to think about that is if it's involving the neck, that could put them at high risk for thyroid issues later on. And then, of course, those stem cell transplants. There's 4 phases to therapy with leukemia. Induction therapy, that first more progressive therapy is 4 to 6 weeks. Then we have prophylactic that occurs for a while after. Then we have intensification and then maintenance. And the maintenance also is checking for CBCs, checking their counts, and making sure everything is okay. Maybe doing another bone marrow aspiration. And this is going to continue for several days. So the CNS prophylactic therapy is only for extremely high-risk kids. Intensification lasts for about 6 months with periodic chemo here and there. And then, like I was saying, month maintenance, they could get daily at first, but definitely weekly rechecks of CBCs and follow up for several years afterwards just to make sure that that patient is staying healthy and they are not relapsing. So I kind of mentioned this earlier, risk for transplants. Morbidity and mortality rate goes up. Graft versus host disease, that's the rejection. So we have to keep a close eye for them. Overwhelming infection can be a problem as well once we have these transplants, and then there can be severe damage to their organs. There is a 60 to 70% cure rate with this, so it is something that they will do, but it is high risk. I find this slide kind of interesting. It's talking about some of the prognosis with kids with leukemia. So depending on what's going on with the child, they can kind of get an idea of how well their prognosis will be. If their white blood cell counts are really close to normal or just slightly low, the kids will have a better outcome than children that have their white blood cells are really far off. Kids between the age of 2 and 9 have better prognosis than kids younger than 2 and kids over 9. Girls tend to do better than boys. And then I found this interesting that we can look at your DNA and find out that just because of what your DNA makeup is, you could have a better success rate with leukemia treatment. And they can look at chromosomes 4 and 10 and see if there's translocations of those. And then they look at DNA index 1.16. So kind of interesting that we can look at that DNA and get a better idea. Also interesting fact, which does not completely surprise me, children with trisomy 21 or Down syndrome have a 20% greater or 20 times greater risk for developing cancer than other children. So considerations, what are those things that we're going to want to look at in their assessment? Skin assessments, perfusion, hydration, intake and output, weight, bleeding tendencies. Do they have petechiae? Are they mottled? Are they losing hair after treatment? Infection, signs of infection, colds, temperature, poor eating, loose stools, things like that. Nursing diagnoses, I'm sure we can come up with tons of things. Remember with leukemia, we want to prepare the child and the family for procedures. Do a lot of pain management and then preventing complications. When we are working with and managing leukemia, it doesn't matter the child's age, but if the child is able to start thinking about their treatment, things like that, we want them involved. So some of your preschoolers, we might have them involved with some parts of their care. School-aged kids, we will definitely have them involved in their decision making. We don't want to hide anything from them. Their opinion is just as important as the parent's opinion. So they have increased susceptibility to infection at the time of diagnosis and at relapse. So we always keep a close eye during those times, during the chemotherapy and the suppressive therapy. So when we're in that intensive phase of their therapy, we want to keep a closer eye on them. That's why a lot of these units are very sterilized, lots of screening of visitors, PPE being worn. It's not uncommon for parents and children to stay away from school if they're at home during parts of the phases of treatment to protect that child. These children probably shouldn't be going out and doing Christmas shopping if they're in the middle of treatment because that could put them at high risk for infection. If they're on antibiotics, things like that. So think about the environment. We want to make sure the parents are doing good cleaning, hand hygiene, maybe even making visitors do those things. We restrict visitors on these units and we screen them just like in the NICU of, okay, do you have these things going on? If you do, you can't come visit. Teaching the parents to look for those signs of infection, fevers, lethargy, changes in the diet. Okay. All right. Chemotherapy agents are very toxic to the skin. So they're vesicants. So we want to make sure that we're keeping a close eye on the sites that we're using to give the treatments and make sure we have meds on hand for extravasation if these vesicants end up causing burns to the skin. There's also high risk for anaphylaxis. Signs of drug toxicity, nausea, vomiting, anorexia, mucosal ulcerations again, neuropathy, cystitis, alopecia, mood changes, moon face. Remember, these kids are also on steroids. They're also on the chemotherapy agents. They're also on other medications to treat their side effects as well and to protect them. So some nursing diagnoses for leukemia. This is just a few. I'm sure we could have a lot more. Caregiver role strain, fear, altered nutrition, risk for fluid, risk for injuries. I'm sure there's even more than that out there that I can't even think of all of them. All right, nutrition for a child with cancer. So nutrition is huge for these kids. Nutrition is so important for our children as they're growing because it's going to help with the maturing of their body systems. It's going to help their brain develop. It's going to help them be able to reach all those milestones and stay on task with their peers. But when they're getting treated for leukemia or other forms of cancer, some of the side effects is that nausea, the vomiting, stomach upsets, poor nutrition. So we definitely follow these kids really closely. We like to look at their preferences and provide them their favorite foods is allowed. Increasing their calories, giving them antiemetics to help them get more food in. If they're constantly hungry at 2 a.m, we make sure that we get their biggest meals and their highest calorie meals in during that time, because that's when they're going to take in the most food. We also throw out some of those stipulations that hospitals have, that you can't bring in equipment and you can't do some of these things. So we allow the parents to have waffle makers. We allow the parents to have crock pots, different things in the patient's rooms, so that they constantly have food at access to them. I believe our new children's hospital actually has little pantries in each of the patient's rooms, so that are constantly full with food, so that whenever that child is hungry, they have quick access to something. Vitamins and mineral supplementations. It's also not uncommon that if we need to, these kids are getting total parental nutrition through their PICC line or their port or whatever, to make sure we're staying on top of their hydration. We are looking at what their preferences are. If they prefer Indian food, we allow the parents to make the Indian food. We have to be careful with some things like fresh fruits and veggies. We have to be careful with those, that if you cannot clean them extremely well because of bacteria and stuff that could be on them, they say to avoid those. So some things to think about that way as well. So canned food typically, or canned fruit, canned veggies, they say are typically the best for these kids. All right, I think that's our last slide on cancer. Yes. Okay. Hyperbilirubinemia. You guys learned a lot about hyperbilirubinemia in Care of the Growing Family, so I'm not going to go into tons of information on this. I believe the figure 24.7, ignore that. I should have deleted that from the slide. So we know that early onset breastfeeding jaundice is due to ineffective feedings. Late onset breastfeeding jaundice, this occurs at 6 to 14 hours of life. Then we have the pathologic jaundice. This is due to ABO incompatibility or Rh isoimmunization. Pathologic jaundice typically also can develop into kernicterus, which is a form of bilirubin encephalopathy. And this can lead to learning and vision and motor issues in that child. So treatments of bilirubin. We will talk about that here in a minute. Okay, so that assessment. Risk factors for increasing in bilirubin. Well, Rh incompatibility, blood typing. Okay, but also if the child has bruising due to the delivery process, being a preemie, they're dehydrated, they're not eating well, birth trauma, polycythemia. Okay. Bilirubin levels, they will look at different things. Typically in a term baby, levels of 15 or lower, we don't tend to get too excited about, but we'll keep a close eye on those kids. Some big things with treatment of bilirubin, feeding them, feeding, because remember, we need to break it down and excrete it through our kidneys and our liver, and then pee it out. So feeding. Phototherapy. Remember, as much phototherapy as possible. So we try not to pull them out from the lights unless we absolutely have to, or for bonding for the parents. So if the mom is breastfeeding, we pull them out from the lights. Mom can breastfeed. If they're just bottle feeding, we could have them hold the baby under the lights in the crib or in the warmer bed and feed them that way if needed. I do that a lot if the parents aren't around. We can do exchange transfusions. These are most common when we have that ABO incompatibility or that RH factor incompatibility, when those bilirubin levels are really high. So what we do with an exchange transfusion is we take out so many cc's of that baby's blood and we put back in the same amount of cc's of donor blood. What's that doing? It's diluting out the high levels of bilirubin. A partial exchange transfusion would be pulling out so many cc's of the baby's blood, putting back in so many cc's of normal saline. So it's 1 for 1. 10 cc's of baby's blood being taken out, 10 cc's of blood or saline putting back in, diluting out those high levels of bilirubin. Education and support. We can do phototherapy at home when their levels aren't extremely high. They have Billy beds, they have Billy blankets, all sorts of things. Remember, the key is as much lights as possible because it helps break it down. Okay, incompatibility issues. This is where we get concerned with high levels of bilirubin. Maternal antibodies respond to antigens from the fetal blood that crosses the placenta. These things result in fetal anemia, jaundice, and hyperbilirubinemia. Okay, so when that mom has like RH incompatibility and we have these antigens from the baby that is of the other type of RH factor, the mom's body will develop antibodies so that pregnancy and further pregnancies after that, those antibodies are formed and mom's body will then end up attacking that baby and future babies. The first baby typically isn't as high risk, but that child could have high levels of bilirubin in their system. ABO incompatibility, similar concept, but it's due to antibodies against the antigens of the baby's blood type. Okay. All right. RH incompatibility. For this to occur, mom needs to be RH negative. Dad has to be RH positive or unknown. Moms will get RhoGAM shots. Moms that are RH negative will get RhoGAM shots at, I want to say, 28 weeks gestation for every pregnancy. She will get another RhoGAM shot again after delivery if that baby is RH positive. If that baby ends up being RH negative, there's no problem. Everything's good. But the next pregnancy, mom will get RhoGAM again. If the baby is positive, mom will form those antibodies against those fetal cells. And then further pregnancies, we will have lysis of red blood cells. Fetal erythrocytes become destroyed by the mom's RH negative or her RH negative or positive antibodies because she's negative. She's fighting off those positives, and those babies could die. Okay. So she's going to get the RhoGAM shot. With ABO incompatibility, if I recall correctly, AB, if mom's type O, there's pretty much no chance of that baby being AB. So typically we won't have an issue because AB would not be developed. But if dad is A, dad is B, there's a chance that that baby could be A or B. Same kind of concept. Mom will fight off antibody. Mom will develop antigens against the baby, and it can cause high levels of bilirubin. There's not a whole lot we can do with it. RH incompatibility tends to be worse. Both kids will get Coombs tests done. Coombs tests are done at the first prenatal visit and then again at 28 weeks, and then they will do it again at birth against the cord blood. If that Coombs test is positive and we see that there are antibodies present in the fetal blood, that means this child is having issues. Okay? So what do? Feed that child. Get stooling going to help decrease the bilirubin. put them under lots of Billy lights, and like I said, we will do exchange transfusions or partial exchanges to remove that fetal blood that has lots of levels of bilirubin. Okay, so some things to think about when they're under lights. We don't put lotion on them. We don't put clothes on them. We want as much of their bodies exposed. They have got little eye goggles on and diapers on. It is not uncommon for their skin to get dry, so hydration is important. So feeding those kids an IVs sometimes to get started. Sometimes they will get a little bit of a rash. That is okay. All right, I think that's it for our PowerPoint. If you have any questions, feel free to ask.